we're back. So after it was our last music session, but again, hopefully we will see each other again next year. And so for the last session, this is the final session of 18th Indoanesthesia 2021. If you remember, 4 weeks ago, we actually opened this virtual symposium with obstetric anesthesia. So I think this is the right thing to do, that actually we will close the session with another obstetric anesthesia session. And so for the final 3 speakers, we hope this is the best speakers. We have 3 speakers. All 3 of them are from UK. Professor David Bogod, Dr. Nuala Lucas, and Dr. Stephen Kinsella. And of course, this session will be led with the one and only Dr. Susilo Chandra. Please, Dr. Susilo.
Thank you, Krisha. I just find that I'm too tight actually, but I'm happy that all 3 speakers is already in our session today, and hopefully all enjoy all the program till this last session. And I would like to invite all 3 speakers. Firstly is Professor David Bogod, and the second will be Dr. Nuala Lucas, and the third is Dr. Mike Kinsella. I think you all know all 3 speakers are all the best in the world of obstetric anesthesia. So without further ado, I would like to invite Dr. David Bogod. We found this is obstetric anaesthetist in Nottingham, UK, and now the president of Obstetric Anesthesia Association and the vice president of Association Anaesthetists Great Britain and Ireland. David, without further ado, please.
Thank you very much indeed, Susilo. I'm just going to share my screen with you, guys. Very kind of you to invite me back, and how lovely to hear your band playing at 9 o'clock in the morning here in the UK. That's really brought the sunshine out in what was otherwise rather a dull and dismal day. Just to put the record straight, I'm Dr. David Bogod, not Professor David Bogod, but the speaker following me is a professor, Professor Nuala Lucas. So she's the one that gets the title. However, let's talk about the medico-legal aspects of obstetric anesthesia, and it's very kind of you to invite me to speak on this particular topic, which has been a lifelong interest of mine. There are some health warnings. I do derive some small income from medico-legal practice. What you're about to see is just an analysis of the cases that have been referred to me over the last 30 years. It's just my opinion, really, frankly. Cases have been anonymized and disguised, so nobody should be able to recognize themselves in any case that's presented here, although I have to say none of them do come from your part of the world. This is what you have to go through in the UK and the equivalent in many other Western cultures if you want to find that a doctor has been negligent in your treatment. You have to be able to demonstrate, first of all, the test is the so-called Bolam test. Was the doctor's practice in accordance with that of a reasonable peer group? And the second test is, was the doctor's practice amenable to logical analysis, which in the UK we call the Bolitho test. If you pass both of those, then whatever the outcome to the patient, you have provided a legal standard of care that is acceptable to the patient and your duty of care is fulfilled. If you have failed on either of those 2 steps, then you have failed in your duty of care. But the patient still hasn't necessarily demonstrated you've been negligent. In order to find that you've been negligent, they need to demonstrate that there's a direct link between your failure of duty of care on the one hand and the damage that they've suffered, whether it be physical or psychological on the other. If there's no such link, then however bad your care has been, you have not been negligent. But if there's a causative link following a failure of duty of care, you could be found to be negligent. And those are the standards that I'll be applying as I talk about individual cases and so on as we go through. When I last analysed my database, which was a few years ago now, approximately 50% of the cases referred to me for expert comment by patients who think they've been harmed by an anaesthetist were obstetric in nature, and approximately half weren't. And you can see the numbers there. They've increased a bit since these figures, but the proportion remains much the same. And of the obstetric cases, I reckon, and this is only me, that there was no failure of duty of care at all in about half of them. That in another 16%, there may have been a failure of duty of care, but it wasn't causative of the injury, leaving approximately a third, slightly over a third, where there may have been negligence. Many of these cases go back a very long way, and nearly all have been settled out of the court system. Very few cases go to court in the UK. And looking at the obstetric cases, what are the regular contributing factors that do tend to cause issues when patients complain about their anaesthetists? And I can look at three features that occur very frequently indeed. Communication problems, record-keeping issues occur in nearly 50% of all cases, and consent issues are on the rise. They're a lower level, but they are increasing tremendously. And the reason consent is increasing is because it's becoming increasingly important, particularly in the West, and I suspect in every culture represented in the audience of this lecture as well. Here's a typical case, for example, that comes from my early days, but which made me wonder about how anaesthetists seek approval of their patients to do what they're doing and how they come to the decisions that they do come to. This is a woman who had first caesarean section, had it under spinal, but needed a sedative drugs for pain. We're not sure what drugs. Second caesarean section, she had a spinal with a slow block, only ascended to T8, and so had a general anaesthetic shortly after skin incision. Third caesarean section had another spinal, but it failed to work effectively, and so she had a general anaesthetic before skin incision. Fourth caesarean section, she had a combined spinal epidural and needed ketamine intraoperatively. And you would think by the time this woman turns up for her fifth caesarean section that the penny would have dropped and she wouldn't have had a general anaesthetic again. Indeed, she was really very insistent that she wanted a general anaesthetic, particularly if she had a placenta previa, but she was told she didn't need a general anaesthetic, and was given a CSE. And lo and behold, she felt pain, and then she sued the anaesthetist concerned. And it's very difficult to come to any conclusion other than there's a failure to listen to the patient in that particular process, and consent is clearly a major issue there. And in the UK, consent's become particularly important since the case of Nadine Montgomery, and that's her with her then 18-year-old son. This lad was born to Nadine by vaginal delivery. Nadine is a very small Scottish lady with diabetes, and her son was a large baby. She was unable to deliver vaginally despite a very prolonged second stage, and went to theatre where she had a really pretty horrendous delivery. She delivered vaginally, and baby ended up with cerebral palsy. It took a long time for her to argue successfully that she should have been offered a caesarean section, at least been told about a caesarean section. And her case went to the highest court in Britain. And this is what the highest court in Britain had to say. There is no reason to perpetuate the application of the Boland test in this context any longer. In other words, when it comes to consent, it's not what the reasonable doctor wants, it's what the reasonable patient expects to hear. Test of materiality is whether a reasonable person in the patient's position would be likely to attach significance to the risk, or the doctor should be aware that the patient would be likely to attach significance to it. In other words, you tell the patient what the patient wants to know, not what you want them to know. This has been now dealt with by the General Medical Council to regulate doctors in Britain under their new booklet on decision making and consent. And I recommend that booklet to anybody who wants to know more about how consent works in the UK particularly. Now, record keeping is another feature that crops up on a regular basis in the cases that I deal with. And this is just one particular case of a patient, again, who felt pain shortly after incision, or possibly shortly after incision, as you will see, under a spinal anaesthetic and needed conversion to general anaesthetic, who later complained about the performance of their anaesthetist. So this is just one case, and look what was omitted from the record that you would expect to see. Was she warned of the risk of pain before she consented to a spinal? I've no idea. Oh, sorry, it was an epidural top-up, not a spinal. Do we know what drugs were given down the epidural? Do we know what block was achieved? No. What drugs were used for general anaesthetic induction? No idea. Did she undergo a rapid sequence induction? What was the laryngeal view? What tube? Was lateral tilt used? Etc., etc., etc. We don't even know whether general anaesthetic was given before or after incision from these records. And the special section on the anaesthetic chart titled Remarks is unfilled. And just as we can make errors of omission in a record, which of course makes it very difficult to defend a doctor many years down the line, we can also look at records and think, I wish somebody hadn't written that in the records. Remember that patients are entitled to see their own records, and if they are unhappy with their care, and they will look at them carefully. And if they see comments like this, they won't like it very much. So this says in a different patient's records, obese +++, difficult to locate iliac crest or vertebral spines, which is probably all right, although the exclamation mark at the end makes it look a little bit angry or excited by the anaesthetist, and that doesn't look good on the record. But the anaesthetist then went on to write, in the notes, could this lady please be persuaded to go on a diet and lose 10 to 15 kilograms? And that is not going to endear a patient to you when they complain about their care later. Because she won't have known this was written in the notes when she complained, but she'll have known it was written in the notes by the time she got the notes back. And I divide problems with record keeping on a spectrum, really, or a continuum, from record keeping misdemeanors on one hand, minor errors, as it were, to what I think of as record-keeping crimes, and some of them indeed are crimes, on the other end of the spectrum. And if you look at the kind of things I'm thinking of here, if you've got a chart that's got prompt boxes specifically on it to record things like height of block, like doses of drugs used, and you don't record anything in those prompt boxes, an empty prompt box itself looks like you haven't paid significant attention to the record and how it should be kept. If you put entries in the notes but don't time them, and certainly don't sign them, it's very difficult to track back when they were made and who made them. If important data is missing, so data relating, for example, to blood pressure and heart rate during a procedure, to oxygen saturation and so on, and those data are later in question, then that looks like something's been missed out, possibly on purpose. And if records that you expect to find in the chart and in the notes aren't there at all, that's even worse. And that's usually it's not because the hospital concerned has removed them for fear of incriminating themselves. It's because it was a tremendously exciting case. It must be, or it wouldn't have come to me in the first place. And the records have been removed for photocopying, for an audit or an M&M meeting, and then not put back in. But it looks terrible to the patient. But that's not as bad as what we've seen just before, making personal or unwise comments on a written record. That's not as bad as the smoothing of records. So we're still in the UK, and I'm sure elsewhere as well, transcribing monitor findings onto a chart rather than getting them printed out directly. And some doctors tend to make the ups and downs of blood pressure and heart rate a little less pronounced than they might be on the actual monitors in order to show what a smooth anaesthetic they gave. And even that's not as bad as deliberately changing or falsifying records, which is where misdemeanors do slip into the level of crime. And I've encountered all of those frequently during my practice. And you can usually spot them, I think. But let's get on to the specific cases related to obstetric anaesthesia. And you can see here the kind of things that crop up proportionally with respect to claims made against obstetric anaesthetists. And the first thing to note, I think, is when you get rid of the general ones, rather surprisingly perhaps, the ratio of regional anaesthetic upset to general anaesthetic upset is surprisingly high. 10 to 1. So for every one case relating to general anaesthesia, I've been dealing with 10 related to regional anaesthesia. And this was way back before regional anaesthesia became the absolute, by far the commonest way of anaesthetizing patients for Caesarean sections. This is back in the days when GAs were as high as 30% in the UK. And yet they're not the ones causing the claims. When they do cause claims, however, you can see they're related to awareness or airway problems. And airway problems, as you might expect, lead to very severe outcomes indeed. And most of the regional anaesthetic claims are not as severe, but more of that in a moment. if we take all cases and take away the ones that are less common, we're left with what I think of as the big five, all of which relate to directly or indirectly to regional anaesthesia. Pain felt during operative procedure, neurological sequelae, headache, backache, and neonatal issues, of which we'll see more in a moment. Divide 21 years worth of data into 3 aliquots of 7 years, and you can see how these are changing as time goes on. And they start, that first cohort starts in 1994, and it goes up to 2014. And you can see that claims for backache following epidurals have diminished quite markedly over the years. This isn't surprising because, first of all, just because a patient gets backache doesn't mean the anaesthetist has failed in their duty of care. And secondly, the link between backache and epidurals is, to say the least, a very tenuous one. So these claims tend to fail. Claims for pain during caesarean section remain much the same over the years. And the sort of case we're dealing with is this kind of thing. This is another one of my category 2 caesarean section. Reasonable epidural to begin with, then becoming poor. Topped up with what was a very reasonable top up at the time for caesarean section. A record that cannot tell me or anybody in the future really what that block was. I don't understand what that says, C-710.7, and I don't think anybody else would either. So I've no idea where that block was. I've never managed to get to the bottom of that, but the procedure was halted 7 minutes after incision, induction of general anaesthetic 9 minutes later, and delivery 2 minutes after that. I worry about the vital signs chart on this one because they're stable all the way through this anaesthetic, despite the patient feeling pain, despite having general anaesthetic induced, which usually after all causes a tachycardia. There's no change in heart rate all the way through, which makes me a little suspicious that they might have been smooth. And there's no comment on the chart as to why pain or general anaesthetic was induced. The patient and the partner, both of whom understandably were present at the time, says the block was tested with an ice cube on the abdomen. She said she could feel it as cold, but they ignored her. She felt pain from the first incision and had pain immediately post-operatively when she woke up, which is always a sign that the block wasn't working particularly well. And with that record and that account from the patient and partner, many years down the line, it's going to be very difficult for that anaesthetist to be able to tell us whether they behaved appropriately. Because it's not necessarily a failure of duty of care if a patient feels pain, but the anaesthetist is on the back foot in trying to defend themselves. These are the features of these cases in general. They're often not warned about the risk of pain. They're often persuaded away from a general anaesthetic for no good reason, as we saw with the first case. They'll often have an epidural that was poor throughout labour, was still topped up with caesarean section. There's often a conflict of accounts, so what the anaesthetist or the staff in theatre remember and what the patient remembers are very different, and also recollections with regard to how the block was tested. Poor records, particularly with regard to block level, what I've described as questionable vital signs, like I talked about in the last slide. Difficult surgery. I mean, there's no block is so effective that it will deal with any problems, all problems that occur during a difficult caesarean section, and that needs to be taken into account. Sometimes a difficult surgeon. Lack of sympathetic follow-up. So patients like this need to be seen afterwards and need to be counselled, and they often aren't. And there's often a very supportive account from the partner who was present at the time, of course. I think of this lot as something I call in a rather colourful manner, the devil's medico-legal pitchfork. These are the 3 things we talked about: communication, record keeping, and consent. And there are features of all 3 here. There are communication problems, there are record keeping problems, and there are consent-related issues. And that's why these cases, pain during caesarean section, particularly crop up frequently in claims related to obstetric anaesthesia. But we spoke briefly before about neonatal issues. And you can see that issues in which the anaesthetist is included in a claim related to cerebral damage to a neonate are very, very much on the rise in the UK and elsewhere in the West as well. And this is a real issue to us because these are expensive claims. So here's data from the UK government looking at what specialties patients are claiming against or in relation to their care of. And you can see that in the period in question, with obstetrics accounts for 10% of all claims against doctors in the UK, but the value of these claims is so high that 10% accounts for 48% of the total value of clinical claims. Because if you've got a brain-damaged baby and you are seeking financial recompense and compensation for that, you are claiming millions and millions of pounds if that baby is expected to live a reasonable length of life. And so these are the claims that are breaking the NHS financially and very many other Western healthcare organisations as well. And with regard to the anaesthetist, they always relate to how quickly we got the patient to caesarean section. Here's a typical case. So this woman went into spontaneous term labour. There was evidence of fetal compromise. FBS failed, the fetal blood sample failed, and so an emergency caesarean section was called. This is the timing points from the anaesthetist. She arrives in the anaesthetic room and is cannulated at 13:31. 4 minutes later, the spinal's completed. 3 minutes after that, she's into theatre. Pretty good going. 2 minutes after that, she has a T4 block. 2 minutes after that, a skin incision, and 5 minutes later, she delivers. But this baby has cerebral damage. Was there a delay as a result of the anaesthetist's actions, and was it a culpable delay? Those are the anaesthetist timing points, but of course there are other timing points. The midwife has the decision made at 13:20, and the CTG disconnection, according to the obstetric expert, which indicates quite effectively the time at which the patient leaves the room, was 13:26, reconnection at 13:27, presumably when she enters the anaesthetic room. These don't look hugely different to the timing points come up by the anaesthetist, but you start to analyse them in depth. The anaesthetist has time from arrival in the anaesthetic room to transfer into theatre as 7 minutes, whereas you take the other timing points into account, that's 16 minutes. That's a 9-minute difference, and 9 minutes can mean millions of pounds in this kind of compensation and have a significant impact on the cerebral damage suffered by the neonate. And getting to the bottom of these cases can be extraordinarily difficult. The common features of them are these: that there are often communication problems between professionals, that timing points sometimes mismatch, and we'll come back to timing points mismatching in a minute. There are often unaccountable delays once the patient gets to theatre. Mothers are perceived as uncooperative, well, they're actually in pain. Panic is often perceived by the mother and her partner, although actually what they're often seeing are people moving effectively and quickly. Women who are in labour where problems are clearly coming up and failure to detect them. The tip of the iceberg syndrome, where in fact there's been significant problems in picking up that the fetus is compromised, but everybody focuses on the time from decision until the time from delivery. And what we call the 30-minute rule in the UK, which has been laid down as an audit standard for delivering women from decision to delivery for category 1 caesarean sections, is largely regarded as irrelevant by most solicitors and many barristers and judges as well. So it's no good saying we delivered within 30 minutes. I think timing points are important, really important. Here's, just imagine this case, for example. So here we have a woman in labour who develops severe fetal compromise. The midwife looks at the labour room clock and calls the midwifery station to activate an emergency. She writes down the time on the clock. At the midwifery station, the coordinating midwife looks at the clock at the midwifery station before activating further responses. She phones switchboard saying, crash caesarean section, we want an anaesthetist, obstetrician and theatre team here now, and switchboard record that using the switchboard timestamp. The anaesthetist is in the corridor, just, perhaps 20 meters away, 30 meters away from the obstetric unit, and picks up the call on his mobile phone, noting the time. The theatre team are in main theatres, sitting in the coffee room, and when the bleep goes off, crash caesarean section, they look at the coffee room clock and record that. The CTG is disconnected as the midwife moves the patient from the room. As she enters theatre, the theatre staff note the time at which she arrives on the theatre clock. The anaesthetist induces anaesthesia looking at the monitor and the clock on the monitor. And finally, the baby is delivered and the midwife looks at her watch. Now, the difference between those various clocks can be little, it can be several minutes, but it doesn't need to be much to make it very difficult to reconstruct events. And more importantly, in a situation where fractions of minutes matter with regard to the degree of cerebral damage, differences between these can prove very injurious to a future claim. And it really is important, I think, for us to get some way. You would think we can now land rovers on Mars, but we still have problems in coordinating timing points on the labour suite. So I'm going to close with a few thoughts about how to keep our patients happy and how to avoid claims against obstetric anaesthetists and indeed anaesthetists in general and doctors in general. It still seems to me, and this is a very specific point, pretty crazy that so many countries and so many hospitals rely on an anaesthetist with a pen transcribing monitor output onto a chart, a paper chart, thus introducing a potential source of confusion, a route whereby somebody may want to try to smooth the records, and certainly an area of conflict between anaesthetist and patient when it comes to finding out what went on. I think many people listening to this lecture will be astonished that this still happens in the UK, but it is a regular feature of UK practice, and really we should be able to print out the output from the monitors now. As I have said, I think clock coordination is extraordinarily important, and we just cannot get it right in the UK. UK hospitals are built in such a way that internet and 4G, 5G signals often fail when you enter the hospital because they're just built in a way that seems to block signals. So anything that relies on an internet signal is often not going to do very well when it hits the hospital. I think this is important. When we did our mandatory training in my own hospital, one of the things we were told was that when you walk into the hospital and you start to encounter patients and staff, you should regard yourself as like an actor who is on stage. You should be listening and thinking about everything you say, and you should remember that the audience, in this case the patients and other staff, will remember what you say and will reflect it back at you later. And I think that's a very good thing to think about, actually. I think we do have to remember that we're in the public gaze when we are looking after patients. I think our interprofessional communication is something that always needs to be considered. In all the years I've been investigating maternity units and hospitals, common feature that you find in hospitals that are failing or have had problems are that the professional groups don't communicate well. Either they're just very bad at it, or in some cases there's actual conflict between perhaps midwives, obstetricians and anaesthetists. And hospitals that are good will always have good interprofessional communication. It needs to be respectful. It needs to be done bearing in mind that everybody is listening to us, and there needs to be a common language that we use. So the person succeeding me in the talks today, Professor Lucas, was the instigator of the 4-point Caesarean section categorization, which is now used worldwide. And that's been a tremendous tool in improving communication between professionals. Patients during regional blocks, I get a lot of problems where patients accuse the anaesthetist of doing terrible things during regional blocks, sticking in the needle 20, 30 times, never talking to them, ignoring their cries of pain and so on. And if you meet a person for the very first time, 5 minutes before they go around your back with a sharp needle and they don't talk to you much, that's going to put you into you're going to feel very vulnerable. And I understand that, and we do need to communicate with our patients at all times. If you've got poor epidural, I think it's between about 30% of UK deliveries are with an epidural in labour if they're delivering vaginally. It varies from around parts of the country. But there's a lot of epidurals out there. And using epidurals for Caesarean sections is absolutely fine, as long as you deal with them if they are poor in labour. There's no point taking a woman to theatre whose epidural has been failing during labour and expect it to work for surgical delivery. So picking it up early and dealing with it before problems arise is key. No good just putting epidurals in and then leaving women to it. This was something I think was more prominent, perhaps, or more prevalent, perhaps 10, 20 years ago. The idea we used to kind of judge maternity units by how high their general anaesthetic rate was, and there was an unspoken thing, certainly in the world of obstetric anaesthesia in the UK. If you had a high general anaesthetic rate, then your unit wasn't very good, and regional and anaesthetists became sort of salesmen for regional anaesthesia, and it's perfectly acceptable to recommend a technique to a woman, but it is not perfectly acceptable to coerce her against the better judgment into accepting something that you think is right for her. And in general, I think one of the things that crops up an awful lot when I'm doing this is block testing, and how we test our blocks and how we deal with the patient. And I would strongly recommend anybody who hasn't seen this, and I think many of you will have seen it by now, to go to the OAA website, that particular URL, and take a look at my interview with Susanna Stanford, who was a woman who was harmed by a poor block during caesarean section. And I'd like to thank her, acknowledge her input into my ability to give this lecture, and indeed into my own professional education, along with my lovely wife Natalie, who was responsible for having put the database together, and my co-author Kate McCoon, and it was with Kate that I've written these 3 articles dealing specifically with lessons from the law for obstetric anaesthetists, and I would recommend those if you want to know more about these particular topics, and particularly neuroaxial blockade and obstetrics, which I haven't dealt with during this talk, with regard to neurological damage. Thank you very much indeed.
Thanks you, David. Yeah, for your info, in Indonesia, we have high-ranking obstetric case litigation. Is in UK only 10%. Yeah? Maybe we have that more cases that can become litigated. So yeah, for us it's necessary to know how to manage before it happens. Thank you for that.
Absolutely.
I want to. If you have a question, my audience, then you can write down on Q&A box. Hopefully, David Bogod will answer directly, or maybe later after all the 3 speakers is already presented their presentation. Now I move to the second speakers, Professor Nuala Lucas. Thank you for let me know that she is already our professor. So Nuala, without further ado, you may proceed your presentation. Thank you.
Thank you, Cecilia, and thank you to the organisers of this meeting. It's a fantastic effort in very difficult world climate for educational meetings, and I really enjoyed the music at the start. You're on fine form, I see. So my remit this morning is to talk to you about updating general anaesthesia for caesarean section. Okay, so over the next 25 or so minutes, I'm going to discuss 2 broad areas. I'm going to talk a little bit about the context of general anaesthesia for caesarean section, and then I'm going to consider some modifications to the current strategy of general anaesthesia for caesarean section. So if we look at global caesarean section rates, unsurprisingly, we've seen a fairly dramatic increase over the last 30 or so years. And there's multiple reasons for this beyond the remit of this talk. But we're in this situation in the world where the World Health Organization has suggested that in some parts of the world, we're doing too many caesarean sections, but in other parts of the world, perhaps the caesarean section rate isn't high enough. Nevertheless, it is at a much higher level than perhaps in 1990. If we look at the trends in Indonesia, the trends in Indonesia mirror the trends in the rest of the world. So regardless of whether you deliver in a private or a public facility in Indonesia, the caesarean section rate has increased. Now, what's the problem with general anaesthesia for caesarean section? Why do we worry about it more than with regards to neuraxial anaesthesia? Well, we have concerns about airway management, the low but ever-present risk of aspiration, pulmonary aspiration of gastric contents. Again, awareness, it's an infrequent, a rare complication, but it can have profound long-term effects if a woman experiences accidental awareness during general anaesthesia for caesarean section. And of course, we always worry about the effects on the baby. Alongside that, we've become much better at delivering neuraxial anaesthesia for caesarean section. We're much more skilled at spinal anaesthesia and using labour epidurals to extend them for anaesthesia. And of course, finally, an important consideration is that our mums want to be awake to see their babies being born. A caesarean section is unlike other operations, and it doesn't necessarily have a therapeutic benefit for the mother. It's a normal life event. And of course, they would be much happier to be awake to see their baby being born. So let's consider, what evidence do we have that there's the problem with general anaesthesia for caesarean section? So the first paper I want to highlight is this very nice analysis from New York. It's a huge database analysis over the years 2003 to 2014. It was a retrospective analysis, and they looked at a range of adverse events associated with what they described as avoidable general anaesthesia. So that was where there was no recorded indication for the general anaesthetic that was administered to the mother for her caesarean section. And they compared the range of adverse events with these same events in women who'd received neuraxial anaesthesia for caesarean section. So you can see huge numbers there. Over 400,000 women received neuraxial anaesthesia. A much smaller, but still very significant number received general anaesthesia. And across a range of adverse events, the incidence was much higher if the woman had received general anaesthesia as compared to neuraxial anaesthesia. And what about if you look at different income settings? And this is a really fantastic analysis from Soha Sobi. She did a systematic review looking at anaesthesia-related maternal mortality in low and middle income countries. And again, if you look at the forest plot below, if I can get my pointer to work, you can see that across a range of adverse outcomes, maternal death, perinatal death, PPH, intensive care admission, cardiac arrest, that these were improved if a woman had received regional as opposed to general anaesthesia. So my take-home message is, compared with neuraxial anaesthesia, avoidable general anaesthetics are associated with an increased risk of adverse maternal outcomes. And I think this really behoves us as clinicians to scrutinise our practice and actively seek ways to improve safety of general anaesthesia for caesarean section. Now, how do we give a GA for caesarean section? Well, if you pick up any textbook, this is the basic recipe. You pre-oxygenate the woman, you induce anaesthesia with an induction agent. I put thio here because this is the one that's still mentioned in a lot of textbooks, although I do recognise that in many parts of the world the shift has been made to propofol. Suxamethonium or succinylcholine, sometimes described, is still described in many textbooks as the muscle relaxant of choice. We apply cricoid pressure with intubation, and after delivery, we give after intubation a mixture of 50-50 oxygen and nitrous is used with a volatile agent. And most textbooks still suggest to give an opioid after delivery. And this recipe has really remained unchanged. And I think the first new advance in GA for obstetrics were the 2015 OAA and DAS guidelines written by the next speaker, Mike Kinsella, was one of the co-authors of this important guidance. So to try and update GA for caesarean section, I want to consider three topics. How should we be pre-oxygenating obstetric patients? What is the role of video laryngoscopy in obstetric general anaesthesia? And how can we minimise the risk of accidental awareness during GA for caesarean section? So first of all, let's look at pre-oxygenation. Firstly, I want to consider how frequent is hypoxemia during GA for caesarean section. Well, these are two nice papers that have been published within the last year, papers that we may have missed when we've been busy managing COVID patients. The first is an analysis from France of almost 1,000 women who had GA for caesarean section. And they found that an instance of maternal hypoxemia, defined as an instance of less than 95%, occurred in 10% of women. So that's 1 in 10 women experienced fairly significant hypoxemia during induction of general anaesthesia. And risk factors were difficult or failed intubation and an elevated BMI. And a similar analysis was undertaken by colleagues in South Africa. And they've, in this cohort, a slightly smaller cohort, but good numbers nonetheless, they found an instance of maternal hypoxemia of 16%, with similar risk factors to the French group. So maternal hypoxemia is not rare during induction of general anaesthesia for caesarean section. So I think a question that we're all asking ourselves at the moment is, what is the role of high-flow humidified nasal pre-oxygenation Could it have a role for pre-oxygenation, optimizing pre-oxygenation, and reduce the incidence of hypoxemia during GA caesarean section? Now, these are two studies that aimed to answer this question. Now, slightly disappointingly, neither of them found a benefit for using high-flow nasal oxygen in this scenario. So let's take a little bit of a closer look at one of the studies. So the study from Australia, both studies were volunteer studies, and this study used 73 pregnant women who received a 3-minute high-flow nasal oxygen protocol. At the end of the 3 minutes, each woman was asked to hold her breath in inspiration, and the nasal cannula used for the high-flow nasal oxygen were rapidly removed, and a tightly fitting face mask was applied to enable the measurement of end-tidal oxygen concentration. They found that the proportion with the first expired breath of end-tidal oxygen of greater than 90% was only 60%, so just less than 2/3 achieved what we would describe as an absolutely optimal pre-oxygenation. They found a negative association of BMI with end-tidal oxygenation, perhaps unsurprisingly. But they did observe that there was no difference in comfort scores between nasal cannula and face mask oxygen. Now, why did this study and the other study fail? Well, I think while I commend the authors for undertaking this study, trying to answer this question, there were some problems with the methodology. The high-flow nasal oxygen, it was possible that the woman was talking or she opened her mouth during the protocol so that she entrained air while breathing the high-flow technique, so perhaps diluting down the amount of oxygen that was inspired. And I think changing the nasal cannula to the mask at the end of the high-flow nasal oxygen protocol also potentially reduced the effectiveness of the high-flow nasal oxygen. But I think perhaps a more important issue is, are we somehow conflating the role of this technique with, instead of pre-oxygenation, should we be rather discussing apneic oxygenation? So that is using supplementary oxygen during the apneic period after induction of general anaesthesia and when the patient has been paralysed. So providing oxygen during this period to try and maintain oxygen saturations. So what evidence do we have for apneic oxygenation? Well, this is a nice analysis that comes from a respiratory simulation model from Nottingham in the UK. And this group looked at the effect of increasing oxygen concentration at the open glottis on oxygen saturation during apnea in the average term parturient. And you can see that with increasing inspired oxygen at the open glottis, remember the patient is apneic, you could prolong the apnea time. Now remember, these weren't real patients, this was a respiratory simulation model, but nevertheless I think it does perhaps demonstrate the potential of apneic oxygenation. And certainly the OAA DAS guidelines that I mentioned at the start have acknowledged the potential role, and they state that the anaesthetist should consider attaching nasal cannula with 5 litres per minute of oxygen flow before starting pre-oxygenation to maintain bulk flow of oxygen during intubation attempts. So I just want to mention another study that has been very recently published in the BJA within the last couple of months. And this group again used the respiratory simulation model from Nottingham to look at the effect of a high-flow nasal oxygen protocol on the duration of safe apnea times in women who've been pre-oxygenated with varying degrees of effectiveness. So they've either reached an end-tidal oxygen concentration of 60, 70, 80 or 90%. And they studied this potential in a range of obstetric patients, so women who've got a normal BMI up to women who've got a very elevated body mass index. So the graph on the left shows patients who are not in labour, and the graph on the right shows the effect on patients in labour. And the different colour points are the different BMI levels. And so if you take a look at the patients who've achieved an end-tidal oxygen concentration of 60%, so you haven't had absolutely effective pre-oxygenation. But by using a high-flow nasal oxygen, you can dramatically extend the apnea time. Now, the benefit is much greater with women who've got a lower BMI, and the benefit is reduced very dramatically in women with a BMI at the higher end, around about 50. And I think this is an important point to make. I think if you haven't used a high-flow nasal oxygen before, but you've only read about it. I think it's important that you're not lulled into a false sense of security. Well, I've certainly found it to be beneficial in my non-obstetric practice, where I've used it more than my obstetric practice. In patients with an elevated BMI, it does not confer such a great advantage. But I think this model does demonstrate the potential benefit with high-flow nasal oxygen. So what's my take-home messages here? Well, I think we have fairly good evidence now that high-flow nasal oxygen does offer the most effective way to deliver a high fractional inspired oxygen at the glottis in the apneic period. And I think it will buy us time. If it buys us time, it's going to reduce stress in what we know is often quite a difficult situation. And I think that if we can reduce stress, we can improve performance. But I can't yet advocate it to be used routinely, because I think there are cost and familiarity implications. So my take-home message here is that we don't yet have compelling evidence to routinely use hair-flow nasal oxygen as a pre-oxygenation or an apneic oxygenation tool. But I do think we have very good evidence of the potential value of apneic oxygen in obstetric GA. And I would absolutely commend you to try and integrate this into your GA practice for caesarean section with standard nasal cannula. Now, the next question I want to consider is the role of videolaryngoscopy in obstetric GA. If we come back to the two studies I mentioned at the start, the French study and the South African study, and I've added to that an observational study of general anaesthetic and airway management practice from the UK, which was also published within the last 12 months. Now, all of these studies found a relatively high instance of failed intubation in obstetrics. And it's interesting because this rate hasn't really changed over the last 20 or so years. Now, if we look at videolaryngoscopy use in these three studies, despite the fact that we know the obstetric population is going to be more difficult to intubate and the relatively high instance I've described, videolaryngoscopy use was very poor in each of these three studies. Now, I want to try and persuade you that I think videolaryngoscopy is an important tool in obstetric GA. So this is a relatively small systematic review and meta-analysis that has been recently published in the Canadian Journal, looking at the role of videolaryngoscopy versus direct laryngoscopy for intubation in obstetrics. They found a relatively small number of studies. If you know that videolaryngoscopy has been around now for approaching 20 years, they could only find a total of 528 patients where its use has been described in obstetric patients. Now, perhaps unsurprisingly, with this relatively small number and a relatively poor evidence case reports and case series and a few RCTs, of their co-primary outcomes, first attempt success rate and time to tracheal intubation, they didn't find a difference between using videolaryngoscopy and direct laryngoscopy. Nevertheless, they did suggest that it does have a role when difficulty with tracheal intubation is anticipated. I want to persuade you why I think that we should be using videolaryngoscopy for obstetric GAs. Now, this is quite an elegant analysis to try and answer this question. And this group suggested the question was choice of anaesthesia for a category 1, the most urgent caesarean section, in women with anticipated difficult tracheal intubation. And they used decision tree analysis to try and work out the effectiveness and the speed of 3 different types of anaesthetics. So they compared the success and time to achieve success using either videolaryngoscopy, awake fiber optic intubation, or spinal anaesthesia for this woman who needs a category 1 section and she's got anticipated difficult airway. Now, I don't want you to look at the actual values here, but what I want to really draw your attention to is the units of time here. So when videolaryngoscopy was used, they were able to rapidly secure the woman's airway in a matter of seconds. But when the other 2 strategies were used, it took minutes. And remember, a category 1 caesarean section is where you really need to deliver the baby as quickly as possible. So time really matters. So what is my view about videolaryngoscopy? Well, I think that we are almost at the time that it should be the first line intubating device. There are some caveats. I think that we have a wide range of videolaryngoscopy devices currently available. I personally prefer a device that uses a Macintosh blade because I think in general terms that is the blade that most anaesthetists are familiar with. And I like to use it as a direct laryngoscope initially. I think we need to recognise the barriers to its routine use on labour ward and think about strategies to overcome some of these barriers. We currently have no short-handled video laryngoscope available. And I think it's important to remember that short-handled laryngoscopes are often helpful. When a woman is lying supine, the upward movement of her breasts can sometimes limit the space between her head and her breast and make it, alongside cryopressure, make it difficult to position the laryngoscope handle. And short-handled laryngoscopes are often helpful in this scenario. And I think that we need to recognise that we have a wide variety of anaesthetists working on labour ward. And when they may be moving around and working in different hospitals with inconsistent devices, I think it would be valuable for us to try and identify the devices that are most effective so we have more consistent types of video laryngoscopes used in the obstetric setting. Now, the final question I want to try and consider is how can we minimise the risk of accidental awareness during general anaesthesia for caesarean section? Now, back in 2015, the 5th National Audit Project in the UK was published, and it highlighted that the incidence of accidental awareness was higher in obstetrics than in other types of surgery. And a range of risk factors were highlighted: drug factors, patient factors, and organisational factors. I think this is always an important element for obstetric anaesthetists to consider. So when we administer a GA for caesarean section, we give our induction agent and we get a rapid increase in anaesthetic levels, and then it will fall off. And in contrast, and then we start our volatile agent. Now, in most types of surgery, particularly elective surgery, it's likely that there's going to be a longer time interval between induction and when surgery is started. In contrast, in caesarean section is much more like surgery is much more likely to be commenced very rapidly after induction of anaesthesia, where at a time when the volatile levels may not yet have reached adequate anaesthesia. So there's what we call a gap in anaesthetic levels, which potentially makes an obstetric patient at greater risk of awareness. Now, we've recently published this work in the UK, the DREAMY study, to try and see if the findings of the NAP5 investigation were actually correct. NAP5 was a retrospective examination of accidental awareness in obstetrics, and this was a prospective investigation of the incidence of accidental awareness during general anaesthesia obstetrics. And we found that NAP5 results were broadly correct. Although it's still pretty rare, it does seem to be higher than in other types of surgery. And we found similar risk factors to the NAP5 investigation. So what can we do? Well, I want to just come back to the recommendations of the NAP5 investigations. And I particularly want to consider some changes to our GA technique. So first of all, let's consider how we give the induction agent in GA caesarean section. In a rapid sequence induction, I think it's traditionally taught as giving a pre-calculated bolus of induction agent. Now, I think that in most rapid sequence inductions, we have largely moved away from this, giving a pre-calculated bolus. And in most scenarios, we actually titrate to clinical effectiveness. And I think in obstetrics, it's one scenario where we tended to have hung on to this rapid administration of a pre-calculated bolus. And I think what we need to do is to make our practice more in line with other areas where we give a rapid sequence, where we use a rapid sequence induction. And I think we need to move towards titrating to clinical effectiveness. I think we've all been in a scenario where we've given a pre-calculated bolus. We've given our 150 or 400 milligrams of thiopentone, and the patient's eyes are still awake at the end of it. So that's my first message. The second aspect I want to consider is the role of opioids. Now, we have traditionally avoided opioids during induction of general anaesthesia for caesarean section because we've been concerned about the effect on the baby. But also we've perceived that if we aren't able to intubate, the lack of opioids is going to help a woman to start breathing rapidly again. Now, with regards to the former question about the effect on the neonates, this is a nice analysis published in the International Journal of Obstetric Anaesthesia, looking at the effect of a range of opioids on APGAR scores. And with most opioids, they found that there was no significant difference in APGAR scores at 1 minute. They did find that fentanyl, there was significantly reduced 5-minute APGAR scores, but at 10 minutes, there was almost no difference. So what are my take-home messages here? Well, the first message I want to make is that use an induction agent you are familiar with and experienced in using. Now, if you think back to the French study and the UK study that I mentioned, there were more problems when the anaesthetist used an agent other than propofol, in particular agents including thiopentone and ketamine. Now, I don't think these agents are inherently awareness-inducing, but I think the problem simply reflects the lack of familiarity of the anaesthetist with these agents. I think we need to be very careful about titrating the dose to clinical effectiveness. And I think you may need to have a second syringe of induction agent ready. And so I would always have a second syringe of propofol, which is what I use these days, ready in case the first syringe is not enough. I think we do not have any evidence that a dose of short-acting opioid, and my preference is to use opioid, has a detrimental effect on neonatal outcome. I haven't really addressed the issue of whether or not it would have an impact on whether or not a patient starts to breathe if there is a difficult or failed intubation. But I think that we are extremely unlikely, in my personal practice, I think I'm extremely unlikely to want to wake up a patient in a category 1 caesarean section, because remember, you're going to be conducting that to try and deliver the baby as quickly as possible. So I think even with a short-acting dose of a short-acting opioid, I think firstly it would have a minimal effect on a woman's ability to start breathing spontaneously again. But I think most of us would probably wish to try and maintain anaesthesia and try and do it safely with the use of supraglottic airways rather than wake the patient up. So coming back to the textbook description of GA in caesarean section, if I was taking an editor's pencil to it, these are the changes I would make. We should be using pre-oxygenation, but I think we should also be making better use of the apneic period. In terms of induction agent, I think we should be using an agent that we are familiar with, and I think internationally this is most likely to be propofol. And I think that we should be very seriously considering using opioid in most scenarios for GA caesarean section, unless there is a specific contraindication you're concerned about. I think suxamethonium or rocuronium both have a role, although I haven't had time to address it in this talk. And with regards to intubation, I do think that we are almost at a point where video laryngoscopy should be the first-line intubating device. Thank you for your kind attention this morning, and I'm looking forward to answering any questions. And if I just could, one small thing, invite you to the OAA Obstetric annual scientific meeting that we're having later this year. We're hoping to have a global event, discuss the problems that we all face. I think we have much more in common than we believe, and I think it's going to be an important time to discuss problems that face us wherever we work in the world. Thank you very much indeed.
Thank you, Nuala. Yeah, we are now lucky because we changed our habit today. We have high flow nasal canal, nasal oxygenation. We have also video laryngoscope, not like in 1970s that everything's only by Macintosh laryngoscope. And yeah, there is so many things that we can discuss after this, but we wait until Dr. Mike Kinsella present the holistic obstetric anaesthetist. It is a very nice talk. Hopefully you can hear now. Without further ado, Mike, please.
Right, thank you very much, Cecilio. Now I'm trying to share. Right. Thank you very much to the organising committee for this invitation to talk about the holistic obstetric anaesthetist. I don't have any conflicts of interest to declare. So what is a holistic? Well, we think about a holistic practitioner being somebody who looks at the whole patient. We can also think about holistic being much more wide view of life in general. So I think a holistic professional is one who's not just interested in the passing gas, just providing an anaesthetic, but looking at the patient both before and afterwards, and also thinking about our interprofessional relationships as well. What's an obstetric anaesthetist? Well, that is very much self-defined. The OAA allows medical practitioners to join if they want to. SOAP considers that the benefits of joining SOAP are that you share similar issues with interested colleagues. So, as I say, it's largely self-defined, but the Global Surgery 2030 report in the Lancet suggested that there were 3 high-value operations that should be provided in all hospitals, including the smallest in the most remote areas, and that includes caesarean section. So I suggest that really the majority of anaesthetists around the world should be doing some obstetrics and having an interest in the particular aspects of the pregnant woman is important and should be encouraged. I'm also not thinking of medical practitioners, whether they're called anesthesiologists or anaesthetists, but others, nurse anaesthetists and medical officers. And we should be trying to encourage them in their professional development and passing on our knowledge and skills as well. So looking at the blue arrow being the duration of a pregnancy, clearly we're involved very much at the time of delivery with providing anaesthesia and analgesia. However, if we look at the small print, admittedly, but we may be consulted even in the preconception period for our opinions. For instance, women who have severe cardiac or respiratory disease, the obstetricians may want to know our opinion on the risks of morbidity and death related to pregnancy. That becomes much more focused during multidisciplinary meetings in early and mid-pregnancy. Again, women with severe pathology, and these meetings should involve the obstetricians and relevant physicians and surgeons, as well as anaesthetists, to plan for labour and delivery. Intensive care can occur both in the prepartum and peripartum periods. And then we also need to be thinking about the patient after delivery, so follow-up, physical and psychological well-being and chronic pain. And just as a couple of examples, in the press in the past few years, there have been suggestions that obstetric anaesthesia and analgesia may be related to postpartum depression and childhood autism and even childhood educational development. Now, these are not, I'm not saying that these are proven, but obstetric anaesthetists have to be involved in these debates to discuss and maybe rebut these. And in the past, a number of decades ago, there were randomized controlled trials of epidural versus non-epidural analgesia in labour to look at the mode of delivery and the incidence of chronic back pain. So we have to be involved in these issues that may involve the patients after their anaesthetic. So just looking at the safety of obstetric anaesthesia, the maternal mortality reports in the UK have been going on for more than 70 years. I've just picked out 3 of the main deaths, direct causes of maternal death: hemorrhage, hypertensive disease, and thromboembolism. Anaesthetists contribute to the management of hemorrhage, and I think we can think of this even the most basic peripheral units where intravenous cannulation fluids and fresh cross-match blood and the use of ultrasonics may be life-saving. And there's a spectrum going up to tertiary care centres where we may have cell salvage and drugs that cost tens of thousands of dollars. Hypertensive disease, there's been I think a very gratifying reduction in the deaths in the UK from ARDS and pulmonary edema in women with eclampsia and preeclampsia in the past few years. And this is because obstetricians and anaesthetists are not drowning their patients by giving them excessive intravenous fluids. And then finally, thromboembolism. Again, here there's a situation where deaths are coming down related to widespread use of low molecular weight heparin. However, there is a potential conflict with the anaesthetist who wants to provide regional anaesthesia in terms of the timing of the low molecular weight heparin. Looking at anaesthesia mortality, well, in the non-obstetric cases, general anaesthesia has become massively safer over the past 60 years, just looking at these figures from 1 in 4,000 to less than 1 in 185,000. Regionals, possibly the improvement is even greater. So in the 1930s, there was a paper suggesting that 1 in 100 women who had caesarean section with a spinal anaesthetic died, whereas now the mortality rate is something like 1 in 1/3 However, because we're doing many more regionals than generals, the absolute numbers of deaths of regionals may outstrip those of general. And this has been highlighted in the South African maternal mortality report. Just looking at the graph on the right there, the deaths from general anaesthesia in obstetrics in the UK came down over the 80s quite dramatically. And in fact, this was before the rise in regional anaesthesia for caesarean section. That's the dark blue line, where it's now more than 90%. And interestingly, deaths from regional anaesthesia in obstetrics have averaged out as about 1 per 3 years over the whole period. So the maternal mortality reports come out every 3 years. And in the UK, as I say, it's about 1 death per 3 years. I'm not going to cover general anaesthesia because Nuala has just done that so effectively. Just to say that any paper that has coronavirus, SARS-CoV-2 or COVID-19 in the title is freely available on the internet. So you can look up all of these papers that have been published in the past year. From the early part of the infection last year, we had recommendations for obstetric anaesthesia in IJOA. And then just recently published in Anaesthesia, airway management guidance for the endemic phase. So acknowledging that we're going to be living with this for several years, we need to get used to new ways of practice. In terms of spinal safety at caesarean section, The suggestions are the main causes of death are high block with or without a contribution of inferior vena cava compression and uncontrolled hypotension. And in 2001, Steve Yentis wrote this editorial, High Regional Block, the Failed Intubation of the New Millennium. Well, numbers are increasing in the UK, but fortunately, as for failed intubation, it can be managed effectively with a sort of ABC resuscitation approach. I mentioned the South African situation where a lot of anaesthesia is provided in small units with by medical officers, and this paper is freely available by Van Rensburg, and it's a very nice, simple diagnostic approach, diagnostic and treatment approach to management of high spinal anaesthesia. However, there's an emerging problem, which is the accidental use of tranexamic acid in the spinal instead of bupivacaine. And this was highlighted by a case series from Sunanda Gupta, 2018, and another one by Santosh Patel in 2019. And I wrote an accompanying editorial along with Arvind Palanisamy. So the problem here is that some countries may have multiple manufacturers of tranexamic acid and multiple manufacturers of bupivacaine. The ampules maybe that are supplied to a hospital may be changing every so often, and they may look very much alike. So the potential for mistakes is great. There are a number of cases that have not been published. We know that. So this is an unknown but increasing problem. But one thing we do know is that if you make this mistake in women having caesarean section, it's fatal in 100% of cases. Looking at the side effects of spinal for caesarean section, this paper in 2004 by Warwick Nagang Key gave women a titrated phenylephrine infusion to manage hypotension. And they randomized the women into 3 groups to either treat the hypotension if it went below, the systolic pressure went below 100% of baseline, 90% or 80%. 4% of the 100 group had nausea and vomiting, and it was 10 times that much in the 80% group. And I suggest to you that we, as a profession, have probably used that 80% figure or a systolic pressure of 100 in the majority of cases. So I was involved in writing an international consensus statement on management of hypotension at caesarean section, and we included detailed recommendations for management in resource-limited situations. And following on from that, David Bishop in South Africa did a couple of very nice studies which were published in Anesthesia and Analgesia and Anesthesia. The first one, they put phenylephrine in a syringe pump and ran it at a constant rate. In the second, they put phenylephrine into a bag given as an afterload, bag of crystalloid, and again ran it at a constant rate, and then gave bolus phenylephrine as required. And the management of hypotension was much more successful in with using these strategies compared with just the standard reactive treatment of hypotension with boluses when it occurred. I'm going to go on to something that may seem sort of very trivial here, but I think it is important. This is our communication with our patients. Women who are going to receive either a spinal or epidural anaesthetic had a local anaesthetic injection in the skin first. They were randomized to be told either that this was going to be an intensely painful injection or that it was going to be a very small scratch, and the benefits of the local anaesthetic were emphasized. The median difference in pain scores in the two groups was 2 points. It was much higher in the first group, who were given the nocebo language. And this significant difference, I suggest, costs nothing, has no harm, but it's a difference which would be considered to be significant if we were introducing a new analgesic drug. So our patients may only receive these procedures once or very few times in their lifetime. I think we, as professionals, this is our bread and butter. We do it on a daily basis. And I think we mustn't get casual about how we communicate with patients, how we put them at their ease, and ensure that their experience is as good as it possibly can be. But getting on to the very much more important issue of pain, and although David has covered this, I'm going to take 2 slides to go through it as well. The top is from a women's magazine in the UK, where the woman says she can feel everything, and then down below something from the internet, a woman who said that she was screaming during caesarean section. The nurse told her that she wasn't feeling any pain, and the anaesthetist said it was all the fault of the surgeon. So we've got 2 major errors here. One is that the patient is not believed, and the second is that there's poor teamwork with the anaesthetist blaming somebody else for the problem. I've been using this slide in lectures for a number of years. It says they don't feel anything, they kick and scream like that when they're confused. Now, surely we can't believe that women don't know if they're in pain. Well, can we? My daughter is an obstetric trainee in a district hospital near me, and just a few weeks ago she was doing a caesarean section in a woman who was in pain for the majority of the operation, and the anaesthetist was telling her that she wasn't feeling pain. This was an absolutely traumatic experience, clearly for the patient, but also for my daughter, who was having to continue with the surgery. So it's 2021. Surely we can't still be having this problem of anaesthetists who don't believe women when they say that they're in pain. And these are the good practice points in our guidelines on our labour ward. So consent and document the block. Sorry, consent and document, test the block and document, communicate the woman and believe what she says, treat the pain, which may include giving a general anaesthetic if that's required. And on the right are itemised bits from the anaesthetic form, which is, I think, a great aid to telling women the particular risks that we need to inform them of, and also reminders of how to document our block, the particular aspects that are required. So after delivery, this is a very recent publication on optimum postoperative pain management in elective caesarean section. This may not just be important for the woman at the time in her first couple of days. A recent meta-analysis of chronic pain after caesarean section studies looked at between 2 to 6 months postoperatively. The incidence overall comes out as slightly more than 10%. But the main risk factor for chronic pain after caesarean section is pain intensity on day 1. So this may be related to difficulties with surgery. However, until that's proven, I think what we need to do is to ensure that we provide the optimum analgesia that we can to try and improve the patient's experience at the time and possibly reduce the incidence of chronic pain as well. Enhanced recovery after surgery is an area that's become much more of interest recently, and SOAP have recently published these recommendations. It's not the strictly speaking enhanced recovery after surgery, but it involves good practice points for the whole procedure, so both preoperatively, intraoperatively, and postoperatively. This has the chance of increasing the patient's satisfaction, reducing the length of stay, and reducing complications. So it may be beneficial in terms of healthcare costs as well as the patient's experience. Just looking more widely at, so not as the not as just as obstetric anaesthetists, but for us as anaesthetists in general. So the US has fortunately rejoined the Paris Accord, but the COVID crisis, in spite of the costs that it has involved to the worldwide community, the environmental change is likely to be a much more significant cost in terms of both money and healthcare, morbidity and mortality to populations around the world. Just looking at the damage that we can do to the environment with our anaesthetic choices, global warming potential 100 is an indicator of atmospheric damage. So for 1 Mach hour of anaesthesia, sevoflurane comes out as 130, desflurane is 20 times as bad. And you can look at the how the damage that you're doing with your anaesthetic with the use of a smartphone app, which is freely available. You can key in which anaesthetic agent you're using, and you can key in fresh gas flows. And anybody that has circle systems certainly should be using low fresh gas flows in order to reduce waste, costs money, and costs the environment. And this is a very recent letter in Anaesthesia, looking at a slightly different measure, which is kilograms of carbon dioxide equivalent, and looking at a 7-hour anaesthetic. And TIVA here coming out at 3.2 is much more beneficial for the atmosphere than inhalational agents, sevoflurane and desflurane. However, in the UK, in the past few weeks, we've had a shortage of propofol. It's been diverted to intensive care. And so we've been encouraged to not use it for in anaesthetic practice unless strictly required. So some of these environmental aspects may be delayed a little bit, but it's something that we can't ignore for very long. again, looking at the environmental cost of producing medicines, this is an analysis of the cost to produce morphine, 100 milligrams in 100 ml bags of saline. It's a natural product, but the production of the farming and the manufacturing is a small proportion of the total. The majority of the environmental cost comes in producing the sterilized bags and then the packaging itself. A recent systematic review of intravenous and tablets of paracetamol shows that both of these are equally effective. But if we look at the cost of the tablets, they're a tiny fraction of the intravenous paracetamol. And equally, there will be a tiny fraction in terms of environmental costs. So we should be using oral medication wherever we can. And the World Health Organization says that the leading cause of inefficiency in healthcare is underuse of generic medicines and paying more than necessary. It's irrational, inappropriate, improper, and incorrect. So I started with the mention of maternal mortality and our contribution to obstetrics, just ending on the concept of multidisciplinary training. So obstetric anaesthetists working with our colleagues, midwifery and obstetric colleagues. And these are results from North Bristol Trust, where Tim Dracos introduced the prompt multidisciplinary training course. And these are real-world outcomes. They're impact studies showing the changes before and after training. So cord prolapse, the decision to delivery interval has decreased over time. Obstetric emergencies training has reduced the frequency of 5-minute APGAR scores and the incidence of hypoxic ischemic encephalopathy in the neonates. And shoulder dystocia training has led to a reduction in obstetric brachial plexus injury. So these are just slides from training that we did at Tangerang Hospital a number of years ago, and the ISOA encouraged and embraced this multidisciplinary training over about the past 15 years, which I think was a great achievement. So I'm not going to give an itemized summary of a talk. Just want to say that I've highlighted just a few of our important professional relationships here, but clearly we're dealing with many other people in the hospital. And again, emphasizing that our care is not just to provide an anaesthetic for the patient, and then that's the end of the job. We need to think of our dealings with the patient both before the surgery, maybe a long time before, as well as after, and maybe a considerable amount of time afterwards. Thank you very much.
Thank you, Mike. Yeah, your last photo is remembering us that you already at least, if maybe everybody know that at least Dr. Mike Kinsella is already 13 times come to Jakarta, not only give a lecture, but also workshop. The picture that we saw before is a workshop. Then if for your info, Dr. Mike, that workshop is mandatory in our hospital, that we do both from anesthetist resident and also obstetric resident. We do it every 6 months, regularly till today. So thank you for that effort. Thanks very much. And yeah, your discussion about holistic is truly holistic, because not just we do anesthesia only, but also for the communication, also for pain, global warming. So it's very comprehensive. I would like to take the time now to the Q&A. Hopefully that some question is already answered by David and Nuala, but I hope that we can also try once again to answer it lively, because this is a very nice question. And maybe there is also question from China, so not just from Indonesia, from China as well. I hope that we can already we can try once again to introduce this in the Q&A. If not bothering you, David and Nuala, you want to answer that question again once?
Sure. David, do you want to talk about one of your questions first?
I'm happy to. Thanks very much, Nuala. I was asked by somebody in the audience, how does one get information across to a patient in an extreme emergency, a category 1 caesarean section situation? And it's extraordinarily difficult. And you are limited as to what information you can give. You just give the essential information that you need to impart to the patient at that time. And if you're trying to make a decision about mode of anaesthesia, you're going to have to get across to her fairly quickly the essentials of that. And then you're going to have to debrief her afterwards, frankly, which is far from ideal, but it's better than not debriefing her afterwards. And far better than all that is to make sure she's got the information before the crisis obtains. And that means picking up on problems early on labour suite. This is all about what Mike was talking about being in partnership with the other people you're working with, being an integral part of the labour ward team, making sure you know about problems. Very, very few problems emerge out of nowhere. They do, of course, we've all seen them, but most of them, we pick them up early and we deal with them. And that's the right time to see patients when fetal compromise is starting, when you know they're likely to be coming your way. That's when you go and visit them and talk to them. And that's when you establish a rapport with them as well, which is equally important.
How about 30 minutes regulation? You mentioned in your slide. It's very unlikely because sometimes we can do it, but sometimes we cannot do it. It is too short sometimes to prepare everything in 30 minutes regulation. What do you suggest?
So in the UK, at least, and I don't think anywhere else, it's not a regulation, but it's amazing. It is amazing how when somebody sets an audit standard, it immediately gets promoted and promoted and promoted until it gets to the point where it becomes a law or a regulation. And of course, life isn't like that at all. In some cases, it's perfectly acceptable to have to wait longer than 30 minutes, even in extreme emergencies. If you're having to do a GA and the patient's a difficult airway, that's the kind of thing that Nuala's described. In other circumstances, 30 minutes is far too long and it would be indefensible. So it's a very useful audit standard, but of course it's been taken up by lawyers and legislators and everybody else in ways that it was never intended.
I know who exposed this, because in Indonesia also 30-minute rule is there here. Wow, it's unlucky.
I'm going to blame the Royal College of Obstetricians and Gynecologists for that one. I think they came up with it, a little knowing that it was going to be sharpened and used as a weapon against them.
Yesterday we have Professor Janika and Dr. Mina discussing about patient safety. I think one of the topic is how about open disclosure. According to my colleague from Indonesia, they now do it in Australia, but we are not yet. How about in UK about this open disclosure to make sure that everybody knows at the first time what happened in the OR or before.
Okay. David,
Nuala, do you want to start on that one?
Well, I think our UK equivalent would be duty of candour. Would you agree, Mike and David? So in the UK, we now have to use a strategy called duty of candour. So that's when a patient has suffered moderate or severe harm, it behoves us to go and speak to the woman, to be frank and honest about exactly what has happened. We have to talk to the woman, talk to any patient, not just in obstetrics, but any patient. And we also have to describe what happened to them in a letter afterwards. I mean, I've got my own views on it. And while I think it is important to be open and honest, I also wonder if it does, in a subtle way, encourage litigation. David, I don't know if you've got any thoughts on that, or whether or not you think, is there any evidence to suggest it has encouraged litigation?
I don't have any evidence yet, but litigation takes a long time to come through. It's going to be, and it's even in the time of COVID, it's been even longer. And I suspect there's a backlog of cases piling up somewhere. In general, no. I mean, as duty of candor it's very formalized, admittedly, but it's still part of the process whereby you communicate and be honest with your patients after the event. And so many of the problems I deal with are triggered a lot by defensive practice on the part of the practitioners concerned, or even an unwillingness to engage the patient or the relatives in any meaningful manner afterwards. Generally speaking, this kind of thing, I think, will if anything, not inhibit, but at least encourage people not to bring lawsuits, because they are likely to be happier once someone's been honest with them. It's the lack of honesty and the lack of candor, I think, causes far more litigation issues than being open and honest.
I do think that there was a well-known obstetric anaesthetist in the UK. In fact, he did lots of things, but called Tony Rubin, and he said that patients are very forgiving, and a truly empathetic apology will go a long way to try and prevent complaints, litigation. And I think for the most part, that is generally true. I think a compassionate and heartfelt expression of sorrow, that this has happened to you. I don't think you have to go and say, oh my gosh, I'm the worst doctor in the world, this is all my fault. But just an expression of regret that a patient has suffered a complication, and patients being dealt with kindly, I think that does go a long way to try and prevent problems.
So thank you very much for that. Yeah, we are far from there. We are still have some obstacle to tell the patient directly the truth. Sometimes we need the time to discuss with obstetrician first, to make same statement, and sometimes it's difficult. And luckily, that the case litigation case is for obstetrician more than for anesthetist. Yep, so we are lucky then. And do you have anything to discuss again, Dr. Prof. Nuala? Lucas?
No, I might address a couple of the questions. Some very nice questions came through. I just want to highlight a comment that Dr. Melin Olsen made. She said that she always, during emergency GA section, she always acts as though the patient is awake. So even though the patient is asleep, she provides reassurance to the woman throughout, whispering in her ear. And I think that is a very nice strategy, actually. It's something I've heard of people doing before, but I think it's certainly useful to remember to do that. So I think it's something I might adopt. Somebody asked a very nice question about, is there any correlation between a higher fractional inspired oxygenation and the outcome of the babies? So I think this issue about oxygenation and superoxygenation is a very interesting one. And it's perhaps the reason why I haven't yet advocated high flow nasal oxygen as the strategy we should be using. So last year in, I think, JAMA, they published a paper looking at the value of oxygen for intrauterine resuscitation. So a woman in labour, the fetal heart rate becomes non-reassuring. So whether we should be using oxygen to try and improve intrauterine oxygenation of that baby. And they didn't find any benefit with using oxygen compared to not using oxygen. So the question is, and we all, secondly, we know from studies that Professor Nanki's carried out is that using supplementary oxygen during caesarean section under spinal anaesthesia is associated with the production of free radicals, which we know can be potentially harmful to the babies. So where does that leave us with using oxygen or superoxygenation at the time of obs-GA? I think it's going to be a very difficult clinical question to answer. And I suspect it's one that we will never get a definitive evidence-based answer to. I think the priority in obstetric GA has to be on oxygenation of the mother, because we know that if the mother gets into problems with her oxygenation, then the baby's definitely going to get into oxygenation. So I think at the moment I couldn't advocate high flow nasal oxygen, as I've said, but I think with an emphasis on trying to maintain normal saturation, normal oxygenation on the mother with the consequent benefit for the baby, I think there is a role for apneic oxygenation. And as for the detrimental effect of superoxygenation, well, I think it's, as I said, it's a difficult question to answer, but remember it would be for a very, very short period of superoxygenation. And I think that when babies have been harmed from high level of oxygenations, for example, neonates with high oxygen levels, that has been for more sustained periods of superoxygenation. Mike, I don't know if you've got anything you want to add to that, because I know you've got an interest in intrauterine resuscitation.
Well, I'd just like to say that paper that you quoted, the title is wrong, because they were looking at studies of women who were administered oxygen during labour, who had no fetal distress in some of them. So in that situation, over a number of years, we've had studies that are not necessarily appropriate models, and that we have gone away from giving oxygen as a routine in the UK and in my hospital. I think that's fair enough, because there isn't compelling evidence for it. But yes, I think in the situation of an emergency, where you might be giving a general anaesthetic, I think there's every reason to give oxygen to fill the maternal lung stores up. The quicker you do that, the better, really.
David, do you have any comment?
Not really. My first ever research paper was done on what we now think of as hyperoxygenation. But I was just pondering on it and thinking that times and anaesthetic techniques have changed so much over the decades that actually we must be careful about extrapolating findings from old studies. And my paper is probably completely useless on the subject now. That did demonstrate some slight improvement in APGAR scores in babies where the mother was hyperoxygenated in the period from induction until delivery. But I don't think that is necessarily going to hold now. And we're now much more aware of the risks of high oxygen levels to neonates than we were before.
Okay. Janica Mellin Olsen is with us as a panelist today. If you want to give a comment or something, Janica, you may.
Thank you very much for such a superb session. It was really something very special. But when it came to the question about open disclosure and candor, I couldn't resist putting myself up for a comment, because it has shown repeatedly that being open, it does prevent court cases. And another issue is that what was mentioned yesterday is that the truth will come forward anyway at some point if you have a feeling that something is left untold. And the candor, you can also go to the US to see with the patient safety movement, how that process, when it's put into a system thing, that you do help the patient through everything and the relatives and tell them where to go to support them and so on, it decreases the level of tension between the providers. And it feels like a relief for the physicians or the health personnel. So there's a lot of evidence about that, and I felt that was very important for me to say. And as mentioned, even in the US, the number one SU station in the world. Thank you very much.
Thank you. David, do you have a comment?
Just to support entirely what Yannicka is saying there. One of the problems I think Nuala might have been hinting about is with regard to duty of candour, is that if you lay a legal requirement upon a hospital, as a duty of candour does, to be open with a patient, it removes the altruistic nature of the disclosure. So if the patient knows that you've been forced into doing it by the law, it doesn't carry quite the same weight. And so the very blunt instrument in the UK that is the duty of candour can bring its own problems. Far better, as Yannicka says, for us just to be naturally open, honest, and go to speak to patients and to apologise if things have gone wrong. Our defence unions have said this over and over again. There is nothing wrong with apologising.
Yes, very nice. I have a question for Nuala. It's a controversial question, I think. It's about, you didn't mention about the use of LMA for GA in C-section. What do you comment on that?
Yeah, I think that is a very good and important area for us to try and address over the next few years. I think that it's been widely described as a very successful rescue measure in obstetrics. So we can't say that it has never been used. I think the question you're asking is whether or not we should be using it as a primary airway device in caesarean sections. I think what we will probably come up with in years to come is that in some scenarios, it may be suitable to use. So in a planned caesarean section, in a woman who's been properly starved, who doesn't have additional risk factors for aspiration, I'm sure that it probably has a role in that sort of scenario. But I think for many women, I think intubation will still remain the safest strategy to manage their airway intraoperatively. I would just say one thing, my personal view about supraglottic airways. They undoubtedly, they are a fantastic innovation in anaesthesia over the last 25 years. And they've improved the safety of anaesthesia. And I think that people like Archie Brain almost deserve a Nobel Prize for their work in this area. But I also think that because we've got them, I think sometimes we overuse them. And some of the issues around difficult airway management, not just intubation, but even holding a face mask, I think we've created that by our ubiquitous use of supraglottic airways. So, for example, when I was an anaesthetic trainee, I used to spend hours holding a face mask on during long cases where paralysis wasn't required. So TURPs, all that. And because we intubated more patients, I think that we were possibly, I don't want to say more skilled, but more experienced in intubating. And now, of course, supraglottic airways are ubiquitous. And I think that we have created some of the problems around airway management in anaesthesia. So I think it's always about striking a balance. And I'm sure there is a balance in obstetrics. And I'm sure that for some women, they may be entirely safe and suitable. But I don't think that it will be, they should be used in all patients. And certainly the scenarios where we're mostly doing GA, so that really urgent scenario in a woman who may not have been fasted, she may have other risk factors, I would advocate using a tracheal tube.
It's very nice discussion, because I found from Lola Clark from United States said that, if we collect the paper, that it is only a myth that LMA is not safe. Yeah, they make so many study and found that no difference between obese patient, non-obese patient, left lateral, supine. The risk of gastric aspiration is same with intubation. sometimes intubation is bigger because we do something, maybe if we use direct laryngoscope, then it takes time, and then sometimes there is a risk of aspiration. It's very nice, interesting. I think
listen, we all love an eye gel, don't we? The question, Nuala is absolutely right. It's not whether we can do it with a supraglottic airway; it's whether we should do it with a supraglottic airway. And those are two very different questions. And I'm a huge fan. I love the supraglottic airway, but we must remember that in NAP4, the Royal College's National Audit Project number 4, which looked at the major complications of airway management in the UK. Over a year, the commonest cause of death was aspiration of gastric contents. It's worth. We think of aspiration as something that doesn't really happen so much anymore. It was the commonest cause of death in NAP4.
Okay, it's interesting. Mike, do you have any comment on this? Or do you want to answer your question from audience?
Yeah, I was just concentrating on that, but I think we in the UK we're very much afraid of innovation for general anaesthetics at caesarean section. The change to propofol is now taking off, but we were using thiopentone because there was a lack of good data and a few early studies suggesting that propofol was bad. So I don't know. I think we certainly won't be switching to supraglottic airways for elective cases, but absolutely for rescue. I think a low threshold for using in the rescue, and if it's working well, then we do have experience of using it for major surgery in non-obstetric cases. I was just a couple of questions that I had. One was it's difficult to be holistic if you're not consulted until the last moment when the patient goes into the operating theatre. Should we offer the consultation during pregnancy? And I think that's absolutely right. Different countries have very different setups, and in France, virtually every woman has an anaesthetic consultation during her pregnancy. So that's at one extreme. In the UK, we don't see every woman on the labour ward until she is requests an epidural, for instance. And we will usually pre-assess patients having a caesarean section, an elective caesarean section, a few days beforehand. But what we have to do is to just try and encourage our obstetric colleagues to involve us, because clearly in terms of patient safety, us knowing problems and planning anaesthesia, it just can't be done at the last moment. So improving interprofessional relationships, I think, is the main issue there, really. And then there was another one. If we don't know whether the block is working, should you change to a general anaesthetic? If we're thinking about the emergency case, it's quite difficult, but you may have a block that is getting better, but you don't have the time to wait. And I think it's clear communication with the patient, and I think talking to them all the way through. So the consent question that David answered earlier, I mean, my point is that we don't have time to give an itemised consent in a Category 1 case, whichever anaesthetic we're giving. So if we're planning on giving a general anaesthetic, we don't say, well, you might have anaphylaxis and a failed intubation, you might be aware, and this, that, and the other, because you're not giving the patient a choice there of either the anaesthetic technique or whether to have this operation or not. Same with regionals. If you're heading towards a regional, there's no point in saying you might be paralysed. So what I tend to say is we can do this with a spinal anaesthetic where you stay awake. We think it's safer for you and the baby. Are you happy to stay awake while we try? And then if the patient says yes, we go ahead with the attempt. But the point where the spinal goes in, that's where you have to communicate with the patient the whole time. You have to get their confidence, and you have to tell them that there's a greater chance with getting pain or needing a general anaesthetic. We can talk to you, you tell us what you're feeling, and we will deal with it if there's there is a problem. And I mean, I've found that works very often in cases where I've thought this block is really quite poor. The patient may well feel pain, but we don't have time. I get ready for a general, but patients often do much better than I think they're going to based on the block. It's not an easy situation, certainly not for the inexperienced person. I think the more experience you have, the more the more the patient will believe in you. If they see somebody like David, who's very mature, they'll think that he's a good practitioner who's done this for quite a while. And so for the trainees, I think it's terribly difficult. But there we go. I'll cut it short.
But sometimes it so happen with us, although we are already 30 years as a obstetric anesthesiologist, it's happened one day. And yeah, usually I decide if it is elective, I do the second spinal for my own experience. In our panelists, there is Professor Chan Yuken from Malaysia. If she want to ask something or discuss about everything, you may unmute your mic. Oh, yeah. Yes, please. Yeah.
Okay, thank you. Thank you for the opportunity. It's been brilliant listening to three great obstetric anesthesiologists talking about the current situation. I was just wondering actually about the oxygenation to the fetus. Nobody seems to have mentioned, I know it's all important, it's probably what you practice as well, the importance of the left lateral tilt or the slight tilt, especially when your baby or the baby is actually in trouble, in distress, hypoxic, so to speak, because a lot of times when the nurses bring the patient in, that part of the practice is not very well observed. And in fact, I once remember a patient who was under my trainee, and she did a spinal, and before I left her, I told her, put the patient down, please tilt the patient. And then before I knew it, everybody was rushing into my theater, the theater that I had just left. And when I returned, the blood pressure was very low, about 30 to 40, and everybody was giving their vasopressor agents. But the patient was actually left supine. And no doubt they were giving the fluids and the vasopressor agents, but nothing worked until the patient was tilted.
Ooh.
So the hypotension was so extreme, no matter how much vasopressor agents you push in, nothing will work as well if the venous return is not going to come back. So I think that's a very important part of oxygen delivery for the fetus as well. And this should be more emphasized than a lot of us are aware of. So debating about whether you should give extra oxygen at the tissue level is probably not going to make a lot of difference, but ensuring cardiac output and adequate flow to the uterus is very important.
Any comment from three of you?
No, just to say, oh, sorry, after you, Mike.
No, you go ahead.
You usually lady first.
Okay, no, just to say that I agree absolutely with YK. I think it's incredibly important. And it's one of those things that we all presume that we're all doing, but it is, I think, forgotten more often than we would like to acknowledge. So yes, no, 100% agree. It's the most important thing you can do. And I sometimes wonder, in cases of profound hypotension where there are problems, if the tilt is not being used sufficiently or at all. But I think I'll defer to Mike, because I think he's got greater expertise on this topic than I have. But I agree with YK.
Well, there's two slightly different points there. One is the use of the lateral position sort of during labour or outside the operating theatre if there's fetal distress, and especially when you're heading towards theatre. And we've done some audits in our unit over the years that it's done reasonably often, but not perfectly. But other units around the country had much worse results when they published their own audits. I think this is something that just takes a long time to educate the obstetricians and midwives into what to do when there's fetal distress, building it into protocols. But yes, absolutely, it's a major part of improving fetal status, that and stopping uterine contractions. When we're in theatre, so hypotension after a regional, for years I've said that we need lots of lateral tilt or the lateral position. And in fact, if you look at the studies overall, when you average it all out, there are not vast effects. And so sometimes there are no effects. And I think what we're missing here is the patient that you're mentioning. So there's a few people who get significant hypotension and are very difficult to manage, especially if they're lying flat. And then one in a few thousand have cardiovascular collapse, and they may need to have full resuscitation with intravenous adrenaline. And sometimes that collapse is not improved by going in the fully lateral position. So you get once you get a situation of cardiovascular collapse, you may only manage to get the woman back by delivering the babies. So in that situation, I think yes, absolutely. If there's time and everybody's not there, certainly increase the lateral tilt, or go fully left lateral. But if everybody's there in that situation, you may need to sort of press on and deliver the babies. But that can be difficult. I had a case once where a woman was hypotensive, and she was vomiting and moving with as much lateral tilt as I could use, and the obstetrician was saying, "Oh, I can't operate with because the patient's moving." And I said, "The patient's going to be moving while she has the baby in. Please start." And it was quite fraught, really. So the obstetricians, unfortunately, sometimes refuse to operate with a patient in the lateral position, but that would be the ideal. But thank you for that point, YK.
Thank you. I think we exceed our time, 3 minutes, but we have to finish our very nice discussion, extremely warm, and hopefully, firstly, I should thank all of you, Mike, David, and Nuala. Thank you for coming again, although it is only virtually, but we are grateful that you are already, you are also accept our invitation. I think I will wrap up everything. Krisha, for that.
Can we just award the bookcase prize to Professor Lucas? I thought she had the best bookcase.
Yes.
You have a nice painting as well, David.
Yeah.
All right, I think this session concludes everything. Actually, we have concluded 4 weeks of Indo Anesthesia. Oh, here comes the bookshelf, virtual bookshelf. Thank you, David. Thank you, Mike. Thank you, Nuala. Stay safe, stay healthy. Really wish that hopefully next year we all can gather again in Indonesia in a better circumstances. Meanwhile, I think this actually wraps everything. Dr. Susilo, Dr. Eddie, do you want to say something?
Yeah. I think I will say in bahasa ya, because audience almost all in Indonesian people. Terima kasih banyak kepada teman-teman semua yang sudah bersedia hadir dari hari pertama tanggal 13 Februari sampai 7 Maret. This is interesting experience for us also, because we use lively virtual, and it is we know nothing from zero, but luckily it's running smooth till today. Thanks again also for the sponsor, for all the speakers. Thanks.
Alright, oke. Untuk teman-teman yang di Indonesia, tadi lupa bilang, hari ini masih boleh ada giveaway kan, Dok? Katanya harus. Masih boleh 3 katanya.
Harus.
Jadi teman-teman untuk pemenang hari ini adalah.
Bye.
Oke, thank you.
Biasanya musiknya telat nih.
Iya.
Musiknya nggak ada.
Nggak ada lagi. Dilangin kali.
Kayaknya udah sampai lupa ngitung berapa hari sih kita 8 kali. Lupa. Ada selamat untuk Dr. Yanuar Syam, Dr. Makmur Sitepu, dan Dr. Yusmin Uyun. Untuk pemenang giveaway hari ini nanti panitia akan menghubungi kepada para pemenang. Terima kasih kepada seluruh rekan-rekan dimanapun berada yang masih ada di OKA, di Poli, di rumah masing-masing. Terima kasih. So I think this wraps up everything. We had fun. Hopefully you guys have fun as well. And see you next year. Stay safe, stay healthy, everyone, and please follow the Indo Anesthesia Facebook account or Instagram account, or subscribe to the mailing list. We will inform you if we have future Indo Anesthesia event. Okay, see you everyone. Bye.
Yeah.